All right, good evening, everybody. Welcome to this 52nd comprehensive course on echocardiography. We have learned a lot about basics of 2D, mode, and Dopplers in last 2 months. Many people have learned about this modality. Many may have misunderstood. Many may have little understood all these modalities. You can revise your talk again and again. You can revise your lesson by going through the video recordings, which we have sent all of you. And in case still you have a doubt, our WhatsApp group is always active 24/7. You get a reply in next 24 hours as you send a question. Moving out from the infancy and moving on to the application of these MO, 2D, and Dopplers, we are going to talk about stenotic lesion as on today. I am Dr. Rakesh Gupta from Jorop Institute of Echocardiography. This is the auditorium which you are going to have hands-on session with us when you come over here. Many learned faculty, including Dr. Parashar, is one of those people over here. Then, on top of that, we have many legends, including like Dr. Nanda, Dr. Parashar, Dr. Chopra, Dr. Samir, behind these training programs. And we have Dr. Hansa Gupta, the president-elect of Academy of Echocardiography. You must have been talking to Reena Dua for a long time. And he's Dr. Narang, who is going to take care of logistics while you're coming for a hands-on training programs. Many accreditations as on today. We have Indian Academy of Echo, International Society of Cardiovascular Ultrasound, Alabama. We do take a permission from a Delhi Medical Council. And apart from that, whenever we are doing hands-on sessions, we have to approach a CDMO for a Northwest District or District Appropriate Authority for their permissions to get the machines and doing the test. We are running a one-year fellowship programs with Parul University for last almost 4 years now. And we have been training echo technicians for NHS in last year. More than 5,000 people have attended these training programs in last 25 years of our training. And we can say that we are the only institute in India providing hands-on training programs. We celebrated 25 years on 17th August 2025 recently, and this is a few pictures from that. Many slogans, which are many trademark or many symbols which have evolved over a period of time. And this is where we started in April 2000 and where we started at 51st second course on 24th September 2025. And today we are going to talk about the application of whatever we have learned in last 2 months, that's valvulose stenotic and regurgitant lesions. And we'll specify for the fact that we are going to talk about MS and TS as on today. And for this, we have a very eminent person, the founder of Indian Academy of Echo, the father of echocardiography in India. Apart from that, the past president of Cardiological Society of India and Indian Academy of Echo. He was bestowed on many awards. The most important one is being by President of India, Dr. APJ Abdul Kalam. He is a co-author of the second edition of Indian Academy of Echo textbook. And he's a legend in himself who's going to take a talk as on today. He's none other than Colonel Parashar. And with this few words, let me have a pleasure of handing over this mic to Parashar sir for his excellent deliberation. And I'm sure that you're going to get benefited with this talk to a large extent. With these few words, let me stop sharing my slides and request Parashar sir to please start sharing your slides, sir.
Slides seen or not yet?
Yes, sir. They are coming up. Now you can bring it, can make them larger.
Just a minute. Is it okay or not?
No, sir, you have to make it bigger by clicking on the wine button, sir. Perfect.
Why?
Sir.
I made it bigger.
It's already there, sir. It's good, sir. Very good, sir.
You can see it now?
100%, sir. We can see
Okay. Say what Dr. Gupta told you and what we have been telling you repeatedly, that the first two talks, that was Doppler and your M mode 2D also, was the basis of the talks. There may be many advantages of an online lecture, but the one disadvantage is that there is a lack of one-to-one interaction, so that we can see how much have you gained till now, how much have you tried to learn, and where you are. So, as I told you, that the first two lectures, and those who have read the first two lectures, they may find it very easy, but those who have not read it, and neither they did not try to clarify themselves, I think they may be in trouble subsequently. Because you know that if there is any doubt in your mind, then you have to get it clarified, which I hope whether you have got done or not. If you have not read it, please read it, and even when you come before for the hands-on, you must read those lectures. And in future, every lecture should be earlier read by you so you can get something. So I'll go very slow, and I'll again go to the basics of some of the previous talks or so that you can get some basic introduction of what we have read till now, possibly if you have not read it before or so. So remember, and I'll go very slow. Instead of 40 minutes, I'll take more than 60 minutes. So I told you, now I don't want to go to the whole, but I tell you that today we are discussing the mitral wall, and the mitral wall is between the atrium and the left ventricle. Hence, it is known as atrioventricular wall. Atrioventricular means between the atria and the ventricle. So that is why it is known as the left-sided atrioventricular wall, the right-sided being the tricuspid wall. So that is the thing that remember it is between LA and LV. And these walls open in diastole. So the mitral and the tricuspid wall open in diastole and close in systole, not like the other one or so. Secondly, I put a stress on diastole and systole because I find that till the last day of the hands-on, persons are not very clear about this thing. And I gave you the example of balloon. When you fill up a balloon with water or air, it increases in size, and when you empty it, it decreases in size. Same thing. This is diastole, this is systole. Same thing in diastole cardiac chambers. When they fill up, they dilate like this. And in systole, when blood is ejected in size, they become smaller. So this is essential for life. Unless there is a systole and diastole, a person cannot remain a sort of a living for even for a second or so. So remember, again, I remember that diastole is when they fill up and systole when they are ejected. So that a receiving chamber is diastole. For example, LV is receiving chamber, it will enlarge in size. RV receiving chamber, it will enlarge in size. Emptying or a feeding chamber is in systole. Only when the LA will contract, then this will fill up. So remember, a receiving chamber is diastole, a feeding chamber is in systole, and same thing is reversed also. So main thing is remember that when one chamber contracts, the other fills up, and when the other one contracts, the previous one also fills up. So remember, and remember one thing, you can interrupt me anytime you want. Don't wait up to the end of the talk. Anytime you can interrupt and get a clarification. So, for example, here you see this is a parasternal long axis view. The mitral valve is closed and aortic valve is open. So that means it is systole because the aortic cusp open in systole and they close in diastole, and the opposite in diastole. You see mitral valve opens, and during diastole, see the LV size increases as compared to systole. So even by this you can know the aortic valve closes and the mitral wall opens in diastole, it fills up the LV, so the size increases. So remember, this is the basis of the diastole and systole, that this chamber size increases or decreases. Then we told you the role of main Doppler is to have a velocity which is converted into hemodynamics, and the velocity are usually in a meter per second or a centimeter per second. So that is the main role of a Doppler. And as we told you, the modified Bernoulli equation, the velocities are converted into gradients. Gradient, as we told you, is the difference of pressure between the two chambers, and this is by this formula 4 into velocity square. So that gives you the gradient. So that is why it is very important to take the correct velocity. If you take an incorrect velocity, the gradients will be incorrect. So I again repeat, anytime there is a doubt, please interrupt me. Now, gradients we told you are usually of two types here. A peak gradient which is related to the blood flow. What I meant was that suppose you are resting and we take a gradient across the mitral wall, let us say, which is the peak velocity gradient. We ask you to climb 10 stairs. And when you climb 10 stairs, your increased blood flow goes into the mitral wall and the peak velocity increases. Hence, it is related to blood flow and can vary on a day to day basis. But the mean is more important because it is the average of multiple gradients. When you average multiple gradients, they are more reliable also. So remember, these are some of the two gradients which you will hear in the world when we discuss the topic. And you see, every time you planimeter a Doppler, anytime you get a peak gradient, mean gradient, and you get a peak gradient, mean gradient, and or add other factors also. So at any valvular disease, we have to undergo a peak and mean gradient, and you can do it by planimetering it, so that the information obtained on tracing any Doppler envelope is a peak velocity and gradient, mean velocity and gradient, and a velocity time integral, that is the distance a blood travels in 1 centimeter in centimeters, the one stroke is known as the velocity time integral. So these are the basics till we have discussed till now, which was all told to you earlier, and you can just recapitulate. Now remember, the most important point I told you during Doppler was any chamber subjected to prolonged pressure or volume overload increases in size. Any chamber you see with a prolonged pressure or a volume overload, pressure overload means like any stenotic lesion, volume overload like a regurgitant lesion increase in size. And second thing I told you that a 2D echo always gives a semi-quantitative idea of severity. So we should not sort of ignore a 2D echo, because 2D echo gives you very good information about the severe semi-quantitative, and this increases in size. Now we come to the main topic. Remember, some of the points may not be very clear to you today, but it will be clear to you subsequently. In any disease, leave aside the stenotic lesion, we always combine a 2D and a Doppler data to assess the severity. So remember, this is always the same in every disease. And in any disease, especially in valvular disease, the sequence of examination is 2D, color flow mapping, and Doppler. This is always the sequence. Your study is incomplete unless you have a color flow mapping and Doppler. Then again, I told you try to get maximum velocities, because if you miss a velocity, your gradients will decrease and we do a valve area. Then you have to take a multiple parameters, we'll come to it later on. See for any intercurrent illness. Suppose any आपको more than 110 or 110 beats per minute, you cannot give a good information. So whenever we get a patient who has got a tachycardia, we tell them not to come today, come any other day. Suppose a patient is having fever, we don't do an echo on the same day, because the fever produces tachycardia, high output state, and all these things. Record heart rate and blood pressure in every valvular heart disease, because it has got a bearing. If today I do at a heart rate of 860, somebody does a heart rate of 100, the values will be different. And as we have repeatedly stressed, always have an ECG. Never do an echo without an ECG. Sometimes you are in a hurry, but it takes hardly 1 minute. Because unless you have got a ECG, you cannot know what is the rate, what is rhythm, what is systole and diastole. Remember, any valvular lesion, see all the valves. Don't restrict. Suppose you got a patient of a mitral stenosis, don't restrict only to mitral wall, but see all the wall. So when you go back today, read this slide again, and anything which is not clear to you, it's because this is the bread and butter of every stenotic lesion or anything. And the same thing here, as I told you we always go from a 2D color and Doppler. Why? A 2D echo gives you a anatomical information. How thick is the wall? What is the size of the chamber? What is the thickness of the chamber? All these anatomical informations are given by 2D echo, and this is the technique which gives you the functional information like an ejection fraction or so. So after this we come to a color flow mapping, because in any Doppler we have to be parallel to the flow. By now you must be knowing that in a Doppler the main prerequisite is that you have to as parallel to the flow as possible. And when you see a color, then you can always say that yes, which side the blood is going, and then you can put your Doppler beam. And this we'll discuss sometime. But every time you see we have been stressing that be parallel to the flow and take the help of a color. So that is why we do these sequence in all these cases. Now, in any stenotic lesion, there is a feeding chamber. There is always an increased pressure in a feeding chamber. For example, in mitral stenosis, the LA is the feeding chamber because mitral wall is between LA and LV. So there's increased pressure in left atrium because it is the feeding chamber. Aortic stenosis, main in LV. Tricuspid stenosis, this is the feeding chamber everywhere. So the feeding chamber that is proximal to the stenosis always has high velocity flow. Nothing new in it, but you have to just remember it that what is a feeding chamber. The feeding chamber is the one which throws the blood into the other chamber. And I hope it is clear to you. Now we'll discuss briefly under these conditions or so that it will make you understand. It is extremely important to know what is the pathophysiology of a disease. Again, I'll go very slowly. As you know, mitral wall opens in diastole. Blood always flows from a high pressure to a low pressure chamber, not from a low to high. So it allows the blood to go from LA to LV in diastole. So mitral wall opens in diastole. Aortic blood goes from LA to LV. LA is the feeding chamber and LV is the receiving chamber. Flow is maintained as long as LV pressure is lower than the left atrial pressure. Nothing very new in it, but only to understand that is the thing. That it is allowed, this is the feeding chamber, this is the receiving chamber. Now, based on this, what happens in mitral stenosis? There is obstruction to the flow from LA to LV because of the obstruction. So when there is an obstruction to the flow, the feeding chamber pressure increases, as we told you. So there is increased LA pressure. So when there is obstruction to the flow from LA to LV because of stenosed wall, the LA pressure increases and the LA size increases. Whenever you hear a word remodeling, it any time it means a change in shape and function. So L increases in size because any chamber subjected to increased pressure increases in size, and then it ultimately leads to atrial fibrillation and LA clot. So that whenever you do an echo, you always see for left atrium. Now another thing, now the basic disease is LA pressure. So this is one cycle. This is another one. The LA pressure is transmitted to the pulmonary veins because the pulmonary veins drain into the LA. So the increased LA pressure is transmitted to the pulmonary veins, and the same increased pressure from the pulmonary veins is directed toward the pulmonary artery. So there's increased pressure. So increased pressure in LA transmitted increased pressure in pulmonary vein, increased pressure in pulmonary artery leads to pulmonary artery hypertension. Now, so though the RV injects blood into the pulmonary artery. So when there is a prolonged increased pressure in pulmonary artery, the chamber the RV increases in size because any chamber subjected to increase the pressure volume increases in size. So there is an RV overload, RVH, and then there is a failure. So we normally don't allow the patient to go into this stage. So I think if you in a pathophysiology, that is when you do an echo, you see the LA, LV in detail, you see the pulmonary artery pressure, look for RVH and RV enlargement, and these are the signs or so. So again, I repeat, Anytime, no any problem, please go on interrupting. So this is the basic pathophysiology. Etiology, this is not meant for you. You are only meant for here. For you, it is rheumatic, rheumatic, rheumatic. Forget about these. These are meant for the higher group of other patients. So for you, it is rheumatic, rheumatic, rheumatic is the main cause of a mitral stenosis. And main thing is there is a fusion of the commissures and some echo finding. When I write this, I've written hands on. Whatever I may tell you now, it will not understand, but when it is shown to you, when it is demonstrated to you, so there is no point in my wasting time to tell you what is commissures and how to record it. It is best to be seen when there is a demonstration of mitral stenosis by Dr. Gupta or when you come on hands-on. So this is the place where the anterior and the posterior mitral leaflets come in contact. So rather than wasting time on it, this is a commissural fusion is the a, main thing in a mitral stenosis. And then there are certain other signs which we'll tell you just now rather than on this basis. So, though you know about the pathophysiology, you know about the etiology, what is the basic for that, and how to what is rheumatic, and now we come to the diagnosis. Now you see, every disease, every stenotic lesion is characterized by when there is a wall-based disease, it undergoes thickening, fibrosis, or calcification. If you are constantly lying on the bed, you also get obese also. So any, because ultimately these are disease of the walls, whether it is aortic stenosis, mitral stenosis, it is disease of the wall. And ultimately it leads to thickening, fibrosis and calcification. And if you are, this is not for you, but if you are asked, what is the abnormal thickening, say it about 3 to 5 millimeters, and how to measure it, we'll tell you just now. So these are the, as the age increases, as expected. When the age increases, the valve is more exposed to thickening and disease. So it is automatically that it will increase in size as with the age also, but average about 3 to 5 mm or so. So, thickening fibrosis, this is a progression. In early stage, there could be fibrosis, thickening, it could be fibrosis, it could be calcification. Sometimes the patients come with a calcification and automatically remember when there is a decrease, the thickening, the opening will be reduced. But the most important sign is a doming of the cusp in direction of flow, that is convexity toward the distal chamber. You must have seen dome. You must have seen a dome in various religious places. Everywhere you have seen it a dome-like structure which is just like this with the convexity up. So now you see this is an important sign. For example, here you see the flow is going from LA to LV. So mitral wall shows a doming. It is a doming that is like a sort of a dome, reverse hockey stick because the distal chamber is LV. So there is a doming of the anterior mitral leaflet. And there you can see the thickness of the base and medial. And I'll just show, and in the you can this is now is not a moving image. So you see the doming. The doming is toward the distal chamber. And if you once you are more expert and you want to measure the thickness, take at the tip of the leaflet from a sort of a distally and measure the thickness here. And you see, and you now this is the so so this is again see a doming, more classical sign, LA to LB, and see the posterior leaflet moves toward this thing, but that will show you again. Uh, Now this is shown as a still image. There is just a thickening or so. And you can see this, the LA is always behind the aorta, and LA is dilated because any chamber subjected to increased pressure increases in size. Now see the aortic stenosis, this is zoomed the view. This is LV, this is aorta. The blood is going from LV to aorta. So this shows a doming toward the aorta, that is toward the distal chamber. You can see it like a doming of the structure. This you can see now. This is doming. Like you see anywhere you see when you You go to your Google and say what is, give me some examples of doming, they'll tell you. Then you go to Taj Mahal, you go to any other place, there is a doming. So this is a doming. Now you see a pulmonary artery. You see this is the RV, this is the PA. And you see the convexity is toward the distal chamber. You see, rather than opening, it shows a convexity toward the distal chamber, and this is how it looks like. So you have seen a doming of all the walls. So this is the convexity is always toward the distal chamber. Similarly, see the tricuspid wall. The flow is going from RA to RV, and you see a doming toward the RV side. So now you see by this example you have seen that this doming is very important sign and also associated with thickness. You can see the thickness of the cusp also. It is not only doming, it is a thickness what we showed at the first time also. So this is the thickness. Whichever wall you see will show a disease wall, a doming toward distal chamber and a thickness. Now see, this is just an M mode, just to tell you that this is posterior. The anterior mitral leaflet and the posterior mitral leaflet. The anterior mitral leaflet goes anteriorly and the posterior mitral leaflet goes posteriorly. Now you see they are going in a different direction. One important sign of mitral stenosis is that the cusps are fused and they move in the same direction. Now you see, just keep an idea. Just also you see this A wave. The A wave moves anteriorly, it moves posteriorly. Same the E. So this is different direction. You see, in a mitral stenosis, they move toward the same direction. So this is known as a paradoxical motion of the posterior cusp. You see again, anterior moves anterior, posterior moves posterior. This is a normal mitral wall. Now here you see there is a restricted opening because the valve is diseased, valve is thickened. But the most important sign is a paradoxical motion of the posterior cusp. So we have assessed about the main diagnosis. So once you know the pathophysiology, etiology, diagnosis, you have seen how we diagnose assessment of severity. Then because definitely when you have diagnosed mitral valve stenosis, the next question will be asked to you, what is the severity? Now you see, as I told you, a 2D echo always gives rise to a semi-quantitative idea. For example, if you see here, now this is a mitral stenosis, you see doming of the cusp, and you see there is a thickening of the basal and the mid segment, the apical and the mid segment, and shows a good opening, relatively good opening of the mitral wall. Now see here, you see, as the disease progresses, the opening becomes much less, as you see here, because as the disease increases, the ball thickens, it becomes less mobile. So here you can see it is still somewhat opening, and the posterior leaflet is moving toward the anterior leaflet, as we showed you in the M mode echo also, because there are fusion of the cusps and the chordae. Now you see here, you see as compared to that, there is more thickening of the cusp, more thickening of the cusp, and there is a you see hardly any motion of the posterior cusp, and you see that means it is more than the mild or so. And here you see it's a calcified wall. Remember, that a doming is a sign of mobility because why the doming occurs, the leaflets are fixed at the annulus and the tips are fixed because of disease. So the only thing which moves is the body of the mitral leaflet. The base cannot move. The tip is restricted because of the disease. The only thing it moves. So as the disease becomes more severe, it may disappear. So that you see here, you see a doming still there, but here you see the hardly any doming. So these 2D echoes tell us that we have what up now. If this patient you are not getting signs of a severe stenosis, that means something wrong in your measurement or so. So you see, this is the 2D echo what I have discussed just now. But you have to go for the quantitative thing, like a mitral wall area. Now, one most important is planimetry. If you are asked what is the one important diagnostic sign of severity of mitral valve, say planimetry. That is the how much is the wall area. That is the most important thing. And at your level, it is determined by planimetry and the pressure half time. We just come to it. Now you see. If you see, this is the guidelines of the American Society of Echo, in which they have graded into various types of mitral stenosis. You can easily read it if you go by ACC, AHA guidelines of mitral stenosis 2014, you get it. Now here you see, they are given importance only mainly to the area in some cases, some pulmonary artery pressure at LA larger, but nowhere they have written the gradients also. So that means the calculation of the mitral wall area is most important. So again you see they have written a stage A, B, C, D as the disease progresses also. So again you see the planimeter it is given also. So, so these are the guidelines you can always read by ACCHA criteria. Now you see, it is the most accurate method for estimation of severity, not affected by any other thing. Now here again I have written hands-on, or when you are demonstrated my telling you theoretically, we can always say that it is, I say leaflet is, but how can you say where the leaflet tip? So here this is a M mode echo, so, or 2D echo. So and you'll be in a short axis view. So but when this is demonstrated, anything I may tell you just now will not click in you, because unless you do it yourself, or unless the case of a mitral stenosis is demonstrated to you by Dr. Gupta as a part of this course. You see, we in a short axis view, we take and trace the mitral wall area. This anterior, this posterior leaflet. It is about 1.5 centimeters square. So the various limitations which will be told to you, but I must say this mostly applies to you. Lack of technical expertise. Therefore, practice, practice, practice. During hands-on, what we tell them, that even in a normal patient, try to calculate mitral wall area. Why? Then you will know how to focus the mitral wall and how to measure it. Because there are many situations where you will have a difficulty in measuring also, especially suboptimal imaging like obesity, and anatomical deformity, and COPD and all these things. So there are other methods also, but because this method is the best, so you always do a lot of practice in these cases, because the main thing is that how to go to a short axis view, how to go to a mitral wall level, and how to measure it. So this again I have let it to the, so don't think that it will be missed, but because it will be shown to you, so as you will understand is better rather than my spending time. And this is only tell you one point, the 3D echo is a gold standard as compared to 2D echo. So if you are asked between 2D and 3D, there is nothing else compared to 3D echo is the most important, is the gold standard for measuring of the 2D echo and give you whole complete information, because we always measure to place exactly at the mitral orbit tip, that tells you 3D echo. Then we come to the pressure half time. Forget about the physics. Forget about the physics. It is now the LA, when it is the mitral stenosis, LA is the feeding chamber, LV is the receiving chamber. So the LA empties into the LV. When the LA sends blood flow into the LV, the LA pressure decreases and LV pressure increases. Very natural thing. Once you are sending a flow through it, it tends to increase and decrease, and then they come in equilibrium. So if you ask a theory, but here I don't want to tell you the time required for the pressure gradient to fall to half of its peak value is the pressure half time. But your job is to get a good Doppler study. The machine automatically gives you mitral wall area by a 220 by pressure half time. So now I'm coming to, now this is severe MS, you see. It takes a longer time for the LA to empty into LV, and longer time takes for the pressure gradient to, it tells to increase in size. So your duty is to get this thing Here, now you see what we do. Now see, this is a mitral Doppler. Now see what we have shown. This is E wave, this is the deceleration slope, this is A wave. Every time there is an A wave there, this is, you see it is comes with the T wave, and you see the mitral comes after this is the diastolic phase. You just draw a line from here to here, it gives you automatically the pressure of time, and the machine also give you the mitral wall area. So your job is to get a good apical view to see the flow, put a Doppler, and you get a good Doppler signal here, and take this in a rough language. I can say it is not a rough language. We don't call it ES slow, but if you see what I showed you in the mitral wall M mode, this was E wave, this was F wave, this was A wave. So, but here this is known as the deceleration slope. Deceleration means that when the atria has emptied and LV is increasing pressure, they try to be in equilibrium and they try to partially close. So you do this, and automatically the machine will give you the with this. So that is your main idea to get a good Doppler envelope. Now there are certain limitations. I will not tell you all limitations. I will all tell you the limitations which we see in our day-to-day life. There's no point in telling you many of these things will you learn later on, not now. These three are the most important problems which we face in our day-to-day practice. Now see, this is tachycardia. We don't know which is the deceleration slope. We don't know which is the A wave. We don't know anything. So we cannot find out anything except the peak velocity. We cannot find out a peak and mean gradient. Now, that is why we always prefer doing an echo at a lower heart rate, below 100, preferably near about 90. The lower the heart rate, the better will be the slope. Now, here what we do not know what to do. So you cannot go on waiting till the patient is sedated, because there are two things because of this. Either the patient is stressed out or there is really some problem. So what normally we do, it may be everywhere different. We give them 25 milligram of beta blocker in the night, and we give them 25 milligram 2 hours before they come to the lab, because it may take about 2 hours for them to act maximally. So that when they come to the lab, eco lab, they still relax there for some time. They still relax, so that we, by giving beta blocker, you have reduced the heart rate, and then what happens? We want like this again. Now this is just to show you that when your heart rate becomes less, you get this as compared to the this. Yeah. So this is our aim. Now here you see the heart rate come to 60, but every time it may not be there. But the main thing is, the idea of this is that you cannot see anything, but here you can see the whole slope, and you can plainly meter it to get a peak and the mean gradient. As I told you that whenever you trace an envelope, you get a peak and the mean gradient. So you see, this is what we do. Second problem we always face is that atrial fibrillation. Atrial fibrillation is very frequently seen as a complication of mitral stenosis. Now, atrial fibrillation, the heart is moving in a very rapid and irregular phases. There may be no A wave, and it is some slopes are very wide, some are narrow. So see, you cannot find out anything here. You cannot find anything here. But during the recording, there is bound to be a complex with a wide diastolic slope. So keep your one finger at a stop button, so that as soon as you get a recording with a wide diastolic slope, you stop it. So here you see nothing can be done, nothing can be done, nothing can be done. And again you see here we have this is one flow, we have done this, and you find the pressure of time is 199 and the area is 1.1. Now remember, in a sinus rhythm, always take 3 recordings. Now, every recording you take, you can try when you are doing your routine echo. For example, suppose you take a mitral and the or an aortic Doppler. All of them will be variable. because of effect of respiration or anything. So it is advisable that in a sinus rhythm, take an average of 3. And in atrial fibrillation, if possible, take an average of 5, but sometimes it becomes difficult also. But in a sinus rhythm, always take an average of 3 readings, and you will see it always all the 3 readings are variable. And the same after this, so we have planimetered it, and we have got a peak gradient of 17, mean of 7.4. So this is how we do it in an atrial fibrillation. We require a lot of patience, and you see again this is the how we do it, and this is the again you see another patient. You see we could not do anything, but here you see that one slope is always wide, and then you press you take it, and you get an area of about 0.5 centimeters square. So this is the thing is that you here you see again you see multiple, nothing can be done there, but there's bound to be a one, there will be a wide diastolic slope, and out of these three we have taken the widest, and here you see we have taken the widest, and this is the mitral wall envelope in that also. So this is how we take a in atrial fibrillation. Third is this, again you will see these three you will find in your daily life also. See, for example, sometimes you will find that the initial, this is mitral wall Doppler, the initial drop is very rapid, and then it gradually stabilizes. You see, this is the initial slope, and then it becomes like this. If you measure here, you will get a very high pressure. 8376 11 Metro. So you see, now here what we have done, we have measured from here to here, and you find an area coming as about 2.4 centimeters square. So you see, the mistake is that just to demonstrate. Measure here. This is the rapid slope. We avoid it. That is just to show. And if you measure from this to this, it becomes covered 1.4. So never measure here. Measure from here and go backwards. You need not go up to this. Go backwards like this. Again, you backwards like this. So this is again I'll show you. Avoid this rapid slope. Go from the mid to the backwards, and again you see. So from 2.4 it's come to 1.4. So this is another thing which you will get very, these three things you will get very commonly. Rest, of course, we'll see over a period of time that how you do it also. Only remember that when a patient has undergone a balloon mitral valvotomy, they immediately send you to determine the mitral wall. Always take a mitral area, not the PhD. So these things are too much for you. But remember, these three are extremely important. What we told you, eh, these three. And these are the problem which we face in our daily life, and we do not get any other much problems or so. Now this again will be hands-on. There is no point in telling you now. A curtain equation is mainly in a hands-on. So by this methods, here you have got a semi-quantitative idea. By you got a mitral area which is the most prominent place in this. You have got it by two methods also, and if you do it well, both of them can be almost the same also. Then this is very rarely done, because unless it is need be also. And you see, so you see, I have put a question mark here as the mean gradient. It is still important. Why? Because suppose your planimetry is bad, your pressure half time is not very correct, then sometimes the mean gradient helps. Mean gradient, by how you calculate it by planimetry, how it helps. Now you see, before 2014, we used to calculate severity of the mitral wall according to area and the gradients as expected. As the mitral wall orifice decreases, the gradient will increase because the LA has to push blood against a narrow orifice. So that was the thing that was the criteria which we used to follow, a mean gradient and the area. At that time, the 1.1 to 1.5 considered a moderate. But after 2014, again I said you can read ACC/AHA criteria. They defined the mitral stenosis or severe when the area is less than 1.5 centimeters square, especially if the patient has some symptoms. And this comes to PhD of this. And so this does not hold true, and they have not given any significant to mean gradient, and very severe is very less than 1. What we call to as a severe, the late is very severe, and what we used to call this one, they made it severe. So if you are asked the criteria for a severe mitral stenosis, then you see according to 2004 outlines, 2014 guidelines, these are the criteria for a severe mitral stenosis. But if you can't get it, then you have to give just idea. Because as you know, even if they are not included it, as the severity increases, the pressure of the volume, this mean gradient will increase. Because if suppose there is this a door from which you are to pushing two persons at a time, they can easily pass. But if the door is closed, you'll have to require more pressure to put the two out of the door. So that is the same thing. The progressively goes on as the area goes on decreasing. And this is how we take a mean gradient. You take it, you planimeter it, and then you get a mean gradient. For example, this much. So the apical view, and then you take now. Out of this, remember, in all stenosis cases, as we told you that we have to be parallel to the flow. So the best view is apical four chamber or a three chamber view where you are parallel. In the parasternal long axis view, you are perpendicular, so you never take a mitral Doppler in that case, but here you take mostly in an apical view, and you trace it and you get this. So, so you have got a pathophysiology, etiology, rheumatic diagnosis both by 2D and by and by say by thickness and by doming, severity by a 2D echo and by the mitral wall area. As a last resort, a gradient, they say that the severe means the gradient more than 10 millimeters of mercury. So you have got a lot of them, but then you have to see the complications or effect of mitral stenosis, which you, all of this you have to write in your report. So I'm telling you this. Complications can be, or effect complications can be like the patient has atrial fibrillation, he can get a cerebral stroke or the heart failure. But what is the effect of MS? Now, see this. This is a parasternal long axis view. You see a doming of the mitral leaflet with a convexity toward the left ventricle, and the posterior leaflet goes toward this. And this is known as a spontaneous contrast echo or a smoke in the left atrium. This is because of a very slow flow state, because of atrial fibrillation, as you see in the ECG, very low flow state. You can see majority of these RBCs also in a low flow state, and when the ultrasonic beam strikes against it, they produce a smoke. And remember, the importance of this is that uh, these these are followed many times by a thrombus. The thrombus may not be visible now. When you see a smoke or the spontaneous contrast echo, always look for a thrombus. Secondly, every thrombus is associated with a spontaneous contrast echo, and this is because of a low flow state. And you can see like possibly, I don't know whether you have seen it before or not. So you see this. Then you can see you can see a thrombus with a significant mitral stenosis, a pericardial effusion, and sometimes you can see a sort of a moving thrombi, and here you can see a marked spontaneous contrast echo, and you see a multiple moving echoes this like this. So this is again sort of a And you see again a spontaneous contrast echo and a mobile link thrombus. This is a transesophageal report. You see a larger thrombus comes and strikes against the mitral wall and against those bags. So the point to remember is that whenever you see a spontaneous contrast echo, look for a thrombus, and whenever you have a thrombus, this spontaneous contrast echo must be present also. Now, as you know, I keep my LV on the left side. So you see that the patient has got a mitral stenosis. How? You see a doming of the anterior mitral leaflet, a paradoxical motion of the posterior leaflet going toward this, AML. And you see, this is the LA, this is RA, and there is a flow from LA to RA as an atrial septal defect. So the combination of mitral stenosis and an ASD is known as the Lutem-Barker syndrome. So now previously it was referred to as a congenital ASD, but now it is whether congenital or acquired, because now a lot of balloon valvotomy is done in which they puncture the interatrial septum, and if they do a sort of a wider puncture also, that can result in ASD. So here you see mitral stenosis and ASD known as the Lutem-Barker syndrome. So always try to see the mitral stenosis in this ASD in this. So this is LA, this is RA, and this patient underwent a mitral valvotomy, and this led to a Lutem-Barker syndrome. Always say hands on. This is left atrial appendage like a fingers projection from the left atrium. Aorta LA. Now this is the importance of the first two lectures of the anatomy, which I don't know you have revised or not. LA is always behind the aorta, and goes in a finger-like projection. This is known as a left atrial appendage. And how to recall that will not be by theory, by demonstration or hands-on. So we have to wait till now. And you can see sometimes you can see the clot into it. You see the moving clot. This is LA appendage, and you see a moving clot. So these are some of the contraindications for doing a balloon valvotomy because it can so you have to see LA. The best technique is transesophageal echo, but still it is worthwhile to see this, and in our hands-on, we insist that in all patients, how do you record LA? It is very easy, and I'm sure all of you will try to do it from the second day onwards. Now, pulmonary artery pressure is a separate topic also, so that has been discussed separately. Now, this is important. Now again, I have written there hands-on. So because if I tell you how to see it is very easy, very important to recall the commissures, anterior leaflet, posterior leaflet, joining at commissure level. In a mitral valvotomy, balloon mitral dilation, they split the commissures. So that is why now what does this indicate? This is anterior, this is lateral, this is medial. This indicates that either the patient has not undergone valvotomy and it is the rheumatic one, or the patient has undergone valvotomy and now they cannot do anything further because you have already split the commissures. Here now the one commissure is split. Here again you see possibly they are still fused together. So these two are good for a balloon valvotomy, while this tells us that a balloon has already been done, and this is both of them have been done. So for example, you see mostly this a lateral one. So this will be shown to you on hands-on. Again, you can see both this and this. See, you can see again some calcification of the commissures, and this is one commissure, this is another commissure. And you can see the still images that this is a split commissure and this is another split commissure. So always see for a commissures to see the number one, because whether it is a rheumatic involvement or not, and what is This one. Now this is a, now you see this is a calcified commissure. Now if you want to split the commissures, it is already it is already calcified. So presence of calcium in the commissure make the wall unsuitable for balloon valvotomy. Unsuitable, you see, it is all now you see here, they are not calcified. Here again, see, they are not calcified, just mildly or so, but here you see there was a significant calcification, and this should not be done. But in a private sector, everything is done. Now, this was an overconfident cardiologist. Despite that, he did a balloon valvotomy, and you see, he has ruptured the anterior mitral leaflet. You can see it. You see anterior mitral, there is a gap, and this has produced a severe mitral regurgitation. So, he treated one disease and produced another disease. So you see, there is a rupture in the anterior mitral leaflet, and this led to severe MR. So one has to be very careful. Now, now these are something again to be shown at that time rather than now. What is known as a these are what we see the Wilkinson score or so, which is based on four things, but surprisingly it does not include the commissures, which is a very important thing also. And this depends upon mobility, thickening, cord involvement. Again, we'll avoid it for the time being also. One another method sometimes which can do, which is very easy, is known as a mitral leaflet separation index. Now remember, if the valve is more diseased, it will open less. If the wall is calcified, it will open much less. So it just indicates indirectly how much is the wall. So here you take a parasternal long axis view, and here you take a apical view. You see the difference. How much do they open? How much do they open? And it is well known that the more severe the stenosis, the less they will open. Nothing new. It is just a simple sort of a IQ. The more disease, the less they open. So below 8 millimeters, it is usually severe, and more than 12 millimeters is not severe, maybe mild or moderate. So so to revise, I have not told you transesophageal, no, but to revise, you start with a parasternal long axis view. You see three things in this. Number one, you see the size of the chambers. You see the spontaneous contrast echo. You see the pattern of this opening of the anterior mitral leaflet. You can see the patient is in atrial fibrillation. So see the anatomy, the RB may be enlarged, LA is enlarged, but three things mainly you want to see is what is the opening index of the mitral wall, whether there is a clot present or not, and that is the thing. And this is only for our clinical interest what we have taken. Wherever you put an M mode, you get the same thing. Wherever in a 2D echo, wherever you put an M mode cursor, you get the same thing. Now here you see uh, there was a spontaneous contrast echo. So we got it just out of clinical interest, spontaneous contrast echo. So you see, now here you see the opening of the mitral wall separate index only 5. So what you see in a parasternal long axis view is for any LV. Beside this, so forget about this side 2D, and at 2D echo you have to do everywhere. So what you see here is what is the any clot into the LA, what is the type of the mitral leaflet, and what is the a separation index. So three things you see in this view. In a short axis view, you see you see again three things. Number one, what is the type of the commission? They are calcified here, and what is the mitral wall area? So one thing you have, so three things you have seen in parasternal long axis view: the separation index, calcification or not, LA clot or not. I'm not going on a 2D. In a short axis view, you again see three things. One is what is the type of the commissures, fused or not, and a mitral wall area. And here you can see a large thrombus in the left atrial appendage, and you can see a spontaneous contrast echo. So that never ignore any 2D findings, and they always give you some information. You see again, this is LA appendage and the clot going into, and you see spontaneous contrast echo. And then you take a mitral valve area, it's about 0.6 centimeters square. So it will be variable. So that is how you take an apical view. As I told you, one mitral valve area. Then you see the subcostal view. But what is the IVC and severe TR? Again, you see any wall. So a guideline for beginners is a domain wall thickness and pliability, parasternal long axis view, mitral valve area, short axis view, and apical by pressure half time, commissures by short axis view, subalveolar apparatus by parasternal long with an apical view, all Doppler studies, preferably CW from an apical 4 and 3 chamber view because you are parallel to the flow. And pulmonary artery hypertension, we take multiple views and this will be told to you. So these are just some of the guidelines or so. And what are the and how do you report? You always give the anatomical appearance of the wall, whether it's a thickened, whether it's a fibrosed, whether it's a calcification, give an anatomical appearance. Always give the severity of the stenosis, mild, moderate, severe, any anatomical complications, MR present or not, and its severity. Because here you see a calcified wall is not suitable for a balloon valvotomy, a MR present or not, a more than mild MR is not conducive for this balloon. So MR degree of pulmonary hypertension, any other valve involvement, commissures and subalveolar apparatus. So they tell us whether it is unable to valve a balloon valvuloplasty or not. So you give a complete information to the clinicians whether valve is to be can be done for a balloon or not, and how type of valve thickening amenable to BMB, type of commissures, that is calcified or what, degree of MR, subalveolar apparatus, LA or an appendage clot, and concomitant severe other valvular heart disease. Suppose the patient has got a mitral and the aortic valve also, so that is always different. The management differs in that case. So now, before we go to the any other thing, any questions till now? Before we go, just 3 to 4 slides of tricuspid stenosis. Everything clear or not clear, or any clarification you want? So your aim is to give all information. If you can't give, always mention the limitation of the study. If you are not been able to give any information, please write. If you are not able to give MB orifice area, please write a high. So just give that also. So again, now coming to tricuspid stenosis, just 3, 4 slides. Again, any chamber subjected to prolonged increases in size. Now there's always an increased pressure in the feeding chamber. So in the tricuspid stenosis, the feeding chamber is in the right atrium. So that means this is the feeding chamber. So the right atrial pressure increases. And so most common cause is still a rheumatic heart disease. That is why in every case of a rheumatic heart disease, please look for a tricuspid stenosis because many times you will miss it also. And there are various other causes also. And you always measure the right sided velocities in and expiration because during inspiration there is an increased flow into the right ventricle. So the gradient of the TR may vary. So always measure it in end expiration, and these are some of the signs of this this severe TS. And what you see here now, just giving an example. For example, here you see This is a right atrial myxoma. It goes through the mitral tricuspid wall, produces a bit of turbulence, producing a functional TS. Why you have written functional TS? Once you remove the myxoma, this will tend to disappear. So just to tell you that we have shown one cause as a tumor which can be seen. So any valvular damage for anything also can lead to this. Now you see. This is you see a mitral stenosis, tricuspid stenosis. Now see that means you so it doesn't take much time. You see there is a restricted motion of the tricuspid wall. There is a thickening of the tricuspid wall, and there is a fairly calcific mitral stenosis. And you see both LA and RA are enlarged. Why? In LA, because this is the feeding chamber, LA, it is enlarged. There is a feeding chamber is the right atrium and pushing blood against it, a restricted mitral or a tricuspid orifice. So their pressure increases, and because their pressure increases, the RA size increases. And again, you see, there is a turbulence. I told you when we were doing a color flow mapping that any disease flow shows a turbulence, and this is a tricuspid regurgitation because this is a tricuspid wall, and the flow comes up from away from the transducer. So this is a tricuspid regurgitation. And I think when you are taught pulmonary hypertension, then it tells you. So and then we take a sort of a CW across it. You trace, and when you trace any wall, as I told you, you get a peak mean. So that means here you see it was almost a very severe tricuspid stenosis because this is VTI almost coming 90, it is 18 or so. Peak is merely 7, and you see the area is hardly 0.90. So this is how we calculate a tricuspid wall. And this is just to show, only showing you that you see, again you see, I'm not showing you what is this case. You see, there is an isolation, thickness of the tricuspid wall, and you see there is a doming of the tricuspid wall, and you see the RA is enlarged. So when they increase the pressure from the end, it is to know that there is increased RA. The increased the pressure in the RA will lead to increased RA dilatation, and because the IVC drains into RA, the same increased the pressure in the RA is transmitted back to IVC, so IVC will also get enlarged. So any questions now? Please read today something, and you have got the full liberty to send any question, email to any of us, and we'll reply also. I
So good
know
evening,
being
sir. I'm Dr. Swami.
yeah.
Dr. Swami, please raise your hand. We'll call you one by one. Okay, you can go ahead. Rest of the people, please raise their hands. We'll call them one by one. Dr.
Yes, sir.
Swami, go ahead.
Yes, sir. Sir, can we differentiate between rheumatic and non-rheumatic mitral stenosis, sir?
Yeah. See, I also told you I did not show you that those things are so because it may be slightly different. Say non-rheumatic will say the basic thing in a rheumatic is that there is a involvement of the commissures. In a non-rheumatic, there may not be a involvement of the commissures. And so as I told you that yeah, I told you that in the rheumatic there is an involvement of the commissures, which are fused in many of the non-rheumatic one because they are not the rheumatic process. There may not be any in the commissures will be there. Now, number two, the disease starts in the valvular region. So the doming is seen in many valvular lesions, but otherwise in many of these may not be seen as this. So, for example, a mitral annular calcification can give to mitral stenosis, but I did not bring it up. Now, this is known as the transient mitral stenosis. For example, a patient of a patient of a left atrial myxoma, like I showed you, right atrial myxoma can produce a transient one. So there are In non-rheumatic pathologies, we can see some cases of a mitral annular calcification, which is known as a degenerative mitral stenosis. We can see hypersomnophilic syndrome, some sort of a calcium in this. And when you come for the course, we'll show you some non-rheumatic pathologies we had, including a including a radiation-induced valvulitis. But the basic thing is that the main thing of a rheumatic is a commissural fusion, thickening at that level, and involvement of the tips of the mitral leaflets. So that is how we differentiate. But in your life, you'll see majority of them will be rheumatic. So I told you. Once you are master of this subject, then we can show you more. But I did not want to overload you at this stage.
Thank you very much, sir.
Anybody else?
Shown any live demonstration of mitral stenosis?
We'll have a live demonstration, sir.
Then you have to read it if you want to really know. Because if you don't read, then what will you gain by getting a live demonstration? All these things will be shown to you, but please read.
Dr.
Sir,
Shikha, go ahead.
sir, this paradoxical movement of valve on M mode, can you please explain it again, sir?
So you see, there is a normally what happens that there is a few in the rheumatic process, there is a fusion of the thickening of the chordae papillary muscles and the mitral, and the leaflets are thickened, and there is a restricted movement of the PML, and they can undergo a sort of a paradoxical lean because of the involvement of the leaflet itself, by a fusion of them. For example, here you see, you can see here. You can see here, the posterior leaflet is going toward the anterior leaflet. The posterior should move posterior, anterior should move anterior. Again, you see the posterior leaflet is moving toward the anterior leaflet. When in a normal case, the anterior should move anterior, posterior should move posterior. And you see here, these are the ones you have. This is simple M mode. I don't know whether you have read or not. You see this is the anterior leaflet. It is moving anteriorly, and posterior is moving posteriorly. So there is no fusion of the leaflet because they are moving in the opposite direction. But when there is a thickening and fusion of the chordae and the cusp, they move towards each other. Now you see here, the number one, the opening amplitude here is good, opening amplitude here is poor, but that can be many other reasons. This is the posterior cusp. So this is the posterior cusp which should move posteriorly. Even if you take final thing, the A wave move anteriorly, and the A wave of the PML moves posteriorly. But here they move in the same direction. So this is known as the paradoxical motion of the posterior cusp.
Okay. Thank you, sir.
Anybody else? No more questions? All right, sir. Thank you very much.
Okay.
Elaborate discussion, and I hope everybody have enjoyed it. And since there's no question, we just stop it over here.
And please revise it before your live demonstration. Otherwise, your doubt will remain like that also. So
So I'll stop this recording and record it again for your attendance.